Hello, dear ones. I am so touched and excited to have with us Dr. Abraham Morgentaler, and he's just an international authority on men's health. Dr. Morgentaler, you're a pioneer. You have changed the way men view testosterone in their life. And I remember back to the time when testosterone was taboo. I mean, no one was allowed to use it. And you, by your work, your research, have really changed that. Now, Dr. Morgentaler is an assistant professor at Harvard. He's a big Harvard man. You got both your medical degree and your urology degree there, right?
Right.
Yeah, and you're the founder of Men's Health Boston. I refer to you all the time and to your group because men really need to have this center where so much is known. You bring together so many different aspects of men's health. And you've written a book. I remember when I first got your book, Testosterone for Life. Oh my God, I bought hundreds of copies and I gave it to men. And it was groundbreaking. And then you wrote about men's sexuality. And God, what was the name of that book? It was Men's...
Well, we started off, it's great to see you, Prudence, and thank goodness for you. You're a true pioneer as well, and I'm just thrilled to be here with you. And thank you for all those kind words. So my last book was called, it started off as being called Why Men Fake It. It came out in hardback. And, it was about stories from my practice around men and sexuality and how men often didn't fit the stereotypes that we attribute to them, especially when they're behind closed doors and they tell what's true instead of, what their persona is that they assume. And the lead story was about a young man who faked his orgasms. And I had never heard about that when he first started telling me about it. I since know a lot more, but I was just intrigued by it. Why would a man even do that? And it really said something about the kinds of motivations and pressures that men feel that I think a lot of us, men included, just aren't aware of.
Yes, there's enormous pressure. Men are in a rapidly changing, I would say, social norm now. Women certainly went through it in the 60s and 70s, and now men are really experiencing themselves in such a different light, in a new way. And there's confusion, Dr. Morgentaler. Men are quite confused. And thank goodness for that book. I'm rushing to buy it as soon as we're done with the summit, and because I love men. And my brother, partner, it's just we're in the more we understand each other and the less suspicion there is, really the greater love we can create. So I'm really interested in, I would have always thought that testosterone was central to urology. Testosterone, men, urology, right? But that's not so much the case. And how did you actually get interested in testosterone and start working with testosterone?
Yeah, it's been some trip, I have to tell you. So I started out really working with testosterone with lizards. When I was an undergraduate at Harvard, I was working in a lab, and nobody was talking about testosterone, but the researchers, animal people, we knew about this. And of course, we've known about domestic animals, what happens when you castrate them and remove their testicles, and whether it's horses or cattle or dogs or cats, right? Like we've observed these things. But testosterone in humans was something that really, people didn't pay much attention to it. So that was in the 1970s, and it's actually kind of cool. So these were American chameleons. They're about 4 inches long, and they're common in Florida and the Bahamas. And if you've been there, they're the guys that go up the trees, and sometimes they get in your hotel room. And and when the male and you put a male in a cage with a female, and they've got this bright colored flap of skin that comes under their neck. It's called a dewlap. And the male sees the female, and the dewlap comes out, and the head bobs up and down very quickly. And it's like the male's going, yeah, 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 yeah. And the female, if her hormones are okay, she'll actually do a very stately push-up. And that kind of says that she's receptive. The male comes closer, the dewlap comes out, yeah, 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 and they end up mating. And if you castrate the male, if you remove the testicles, then they have no testosterone. They put the male in a cage with the female, and they don't do anything. They don't do anything. The female will sometimes do a little push-up again, like, hey, buddy, I'm over here. Like, like, come on over.
Yeah, we
And
do
the
that in real life.
males don't care. And so my experiment was actually to put tiny amounts of testosterone in the brains of these lizards. And we had identified which were the sexual centers in their brain. And I wasn't always successful, but when I was, these males without testicles would be put in the cage with the female, and the dewlap would come out, the head would bob up and down, and they would mate again. And it was unbelievable. And so I did those studies in the 1970s, and I recently wrote a 40-year perspective on testosterone. My first paper was 1978. And what I got from that was that testosterone was a brain hormone, and that it was necessary and sufficient for sexual behavior in the male lizard. When I came out of my training in urology and started doing work with men in 1988, there was almost no testosterone used in this country. Yeah. And what we thought about testosterone was it was dangerous for prostate cancer. So we didn't have much to offer these guys who had sexual problems. There was no Viagra or Cialis yet. And so because of my lizard experience, I thought maybe men are like lizards. And I just started testing some of these guys and was surprised at how often their levels were low. It turns out we are like lizards, Prudence.
Good lizards.
we're like the good lizards. Thank you. And so I started treating some of these guys, and they did remarkably well. But our fear was that it was going to cause prostate cancer. Right. And that really led me on what became the primary focus of the rest of my career for the next 30 plus years.
Wow. So I would love to hear your story, of going from, because when I did my urology rotation in my first year of residency, and it was like testosterone is the fuel that feeds prostate cancer.
Right.
Really, this was 83. Nobody was speaking about it, and it was dangerous. So what is this story with testosterone and prostate cancer, how it basically was man's enemy to really fairly heroic, I would say?
Yeah. So by the time I came out, the only men who were getting testosterone in this country and pretty much around the world were young men who had lost their testicles to cancer or trauma, or had pituitary tumors that had been resected. Like, it was clear that young men needed testosterone in order to develop as men and to be sexually active, to be muscular, etc. There was a problem with once they got to their middle, 40s and above, because then they started worrying about prostate cancer. And that original story came from Huggins in 1941, won the Nobel Prize about 25 years later. Charles Huggins, University of Chicago. And in the 1940s, there was no treatment of any sort for any prostate cancer. And what he did based on experiments in dogs was that he castrated these men with metastatic prostate cancer. They didn't have PSA then. They had another test called acid phosphatase. Mm. And when he removed the testicles, acid phosphatase came down, just like we would expect PSA today to come down. And he also gave it to a few men, and their acid phosphatase went up. And so he concluded testosterone activates prostate cancer. And ever since then, everybody's been deathly afraid to give it. And even today, however many years later, 80 years later, every testosterone product has in the label that it's contraindicated in men with cancer, and even in men with suspicion of prostate cancer. So when I came out in 1988 and I started doing some of this work, and I saw how well some of these men did, I would talk to them about what are the risks? They would say, doctor. And I would say, well, we worry about prostate cancer. How can you check for it? Well, we'll follow your PSA and I'll examine you. And some of them didn't feel like that was so great. And at some point I decided I better start biopsying the prostates, because once I saw testosterone really worked to help men for all the reasons that not just with sex drive, but also mood and strength and vitality and sharpness of the mind. Like, these guys felt like their lives were so much better. And I realized that if I was going to do this, I needed to really exclude the possibility of prostate cancer. So I started doing prostate biopsies before I gave testosterone in the men, even if they had a normal PSA and a normal prostate exam. So prostate biopsies weren't that much fun then. They're a little bit better now, but still nobody likes it. But a lot of these guys were really hungry to sort of have something done and have their lives improved. And the belief back then was that high testosterone caused prostate cancer. Low testosterone was believed to be protective. I was trained that if a man lost his testicles early in life, that man could never get prostate cancer. And yet right away, these men with low levels of testosterone, we found them to have prostate cancer. And I remember we presented, when we had 6 out of 33 cases, I had my fellow present this data at our national urology meeting, the AUA, and this international figure came to the microphone. He had a huge booming voice, and he said, "This is garbage. Everybody knows high testosterone causes prostate cancer. Low testosterone is protective. You guys stuck your needles places you never should have stuck them. You found cancers you never should have found. I'll bet you dollars to donuts. You can biopsy another 100 guys, you won't find another cancer."
The gauntlet is thrown down.
Thank you. What are you going to say? Thank you for your comments. We're just reporting what we found. And then when we had 50 cases and the numbers were still about 1 in 7, I submitted it to the Journal of the American Medical Association. And something happened to me then that's never happened before or since, and I've published about 200 scientific articles now, which is that the editor called me on the phone. You know, normally it's all from a distance, emails and whatever. Back then it was by mail. And he said, "Listen, our board just discussed your paper. We find it very interesting. But you know, you only have 50 guys. And it's the opposite of what we've all been taught. So I tell you what, if you can collect more patients, the numbers hold true, we'll consider it again." And when we had 11 cancers out of 77 men, we resubmit it, and it got published in JAMA in 1996. So here's what that meant. It meant that at least part of the story of testosterone and prostate cancer could no longer be true. We had high rates of prostate cancer, higher than it should have been, in men with low levels. The old teaching was high testosterone was a problem, low testosterone was protective. Half of that story was no longer true. Fast forward to 2004. Testosterone is now sort of out a little bit more in the public. There's now a testosterone gel that had come out in 2001. Doctors were now getting detailed on the fact that this was there. The Women's Health Initiative for Women in Hormones had come out in 2002. So there was some interest in hormones and what are the risks in men. So the New England Journal of Medicine was interested in a review article, and we wrote that up, we meaning my fellow and myself. And at that point, I was clear that low testosterone wasn't protective, but I still believed, because it was my training, that high testosterone was dangerous in some way. Poorly defined, but in some way it must be bad. And we pulled together about 200 papers, and this is on the risks of testosterone, and we're focused mainly on prostate cancer. And my fellow comes to me. He's a very confident guy. He's now a prominent urologist in Brazil, and he looks nervous. And he says, "Chief, we're about to write the article." He says, "Chief, do you have the articles that show that testosterone is bad for prostate cancer?" And I said, "Ernani, I thought you must have them." And it turned out that what we published was that we couldn't find a single article, not one, that showed any compelling evidence that high levels of testosterone were in any way, or testosterone therapy, were in any way related to risk of getting prostate cancer, high-grade cancer, or stage with cancer, progression with cancer. We couldn't find anything. And yet that was taught around the world.
It's unbelievable. That's really unbelievable.
Yeah.
That
So it started a whole new, do I have sunlight? It started a whole new thing for us. And then I started treating some men then who had prostate cancer with testosterone. And I'm just trying to get out of the sunlight here.
You are illuminated, my dear.
The beauty of a skylight is it lets the light in, but sometimes it's not always what you want. And, you know, if I fast forward, I can tell you today that I've now treated many hundreds of men who have prostate cancer with testosterone. I don't give them the testosterone to quiet their cancer, although there may be some evidence that that may be useful, but it's mainly because they have a need or they're deficient and symptomatic. And I no longer believe that testosterone is dangerous for prostate cancer.
Right. And I think that's been so well written about in terms of your work and so widely publicized that I think, are urologists starting to catch on to that fact?
So it's better than it was. So I think that most of the urology community has now accepted, and the oncology community has accepted, that if somebody has had prostate cancer, that they were treated, surgery or radiation, they've had a good outcome without any evidence of recurrence, that there's minimal, maybe zero risk if they go on testosterone. I think that's the part that's accepted. Most urologists will still have their patients wait 2 years after surgery. But you know, it's funny, we learn things we think we're so smart in medicine. And really, we're just following a lot of the stuff that we were taught. And you know, the rules around testosterone and prostate cancer, it came before even our teachers and our teachers' teachers. It's just been this assumed knowledge, this conventional wisdom that's been handed down without any kind of challenge or questioning, or when does it apply, when does it not apply. So, you know, I had some years ago, I had an 84-year-old attorney come see me. And, you know, his sex drive was down and he wanted his sexuality to be better. And I said, listen, you know, it's, you know, at your age, it's a good chance your testosterone is low, and I bet it might help you. So let's get a blood test. So we got the blood test, and sure enough, it was low. But he also had a high PSA.
Yeah.
So it was like, if I remember right, it was 8. And, you know, I said to him, listen, sir, you're 84. I don't do a lot of biopsies in men who are 84, but you're in great health. And, you know, if you have an aggressive cancer, we might want to know and treat you. If it's not aggressive, maybe we'll just leave it alone, or maybe you don't even have anything if we do a biopsy. He says, I'd like to know. So I biopsy him, and he has low-grade prostate cancer, what we call Gleason 6. Probably won't ever hurt him in his life. And so I tell him that's what he's got, and I'm ready to leave the room. He just wants me to watch it. And I say, I think that's a good idea. And then just as I'm leaving, he says, but what about the testosterone doctor? Now, this was some years ago, and we were going to follow him, which we now call active surveillance. It was new days for that. And I said, well, I can't give you testosterone. You've got untreated prostate cancer. And he's a lawyer, and he was still very sharp. He said, doctor, if you give me testosterone, will it make my PSA go up? Could we follow it that way? I said, that's logical, but I don't know because I've never treated anybody like you. He said, if the PSA goes up with testosterone and we stop testosterone, won't the PSA come back down? I say, that's also logical, but I don't know because I've never treated anybody like you.
Wow.
He says, doctor, I'm 84 years old. I've got to go sometime.
Attorneys don't usually feel that way.
But while I'm on this planet, I'd like to live as well as I can. And would you please treat me, and I'll sign any consent form you want. And I ended up treating him, and I was nervous. Like the very next day, I was like, what's going to happen to him? because this really is where the rubber meets the road, right? Like you can write all your conclusions from data, whatever, but here was a guy now living, my patient in front of me with untreated prostate cancer, and he wanted it to be treated with testosterone. And I ended up publishing on him after 2 years. His PSA started in the 8s. It actually dropped into the 7s, dropped into the 6s, and stayed there for 2 years. He was my patient on testosterone for a total of 6 years. His PSA never went anywhere. We stopped when he was 90 because his wife brought him in. He had dementia at that point. So there was, we let it go. But he gave me then the courage to start treating men, which for what is now pretty common for us to do, which is active surveillance, where we're just watching guys who have low risk cancers.
You know, what year was that you saw your first patient like that, you know, for who had prostate cancer?
I'd have to guess. I would guess it's about 10 years ago.
10 years ago, because I remember you mentioning that you had a study with men who had stage 4 prostate cancer and needed testosterone and who wanted testosterone, and they were doing pretty well. Is that correct? Is that?
Yeah. So we're actually writing up now. So I've got a number of men with metastatic disease. Yeah. And men who have recurrences of their cancers after treatment, which we call biochemical recurrence. And on the whole, they've done really well. Now, listen, people with prostate cancer that has spread, there's the natural history of that is that continues, right? Like it progresses on its own, whether they get testosterone or not. But the traditional treatment for those men has been to eliminate their testosterone completely. We call that androgen deprivation. And, you know, there's some increase in survival, not amazing, but some increase in survival. But a lot of those men are just miserable. Oh. They lose their strength, they lose their personality, they lose their motivation. So I've had a couple of these guys. You know, I had one guy who had surgery. He was relatively young, in his 60s, and he had surgery for prostate cancer. They found lymph nodes. So they left his prostate in place, because what's the point? And they radiated him, and they started him on androgen deprivation, these medicines like Lupron. And he was so miserable. So he came in with his wife, and nice guy. And he said, "Doctor, I'm so weak that I can't raise my hands up in the shower to wash my hair." Yeah. The wife tells me, "He's the most sociable person you've ever met. We don't leave the house anymore. He feels that he's not comfortable driving. We had our favorite restaurants. We don't do anything." And he wanted to be on testosterone. We ended up treating him. First, we stopped the androgen deprivation, and everything comes back. It's like his personality comes back. He starts driving. They go to the restaurants. They see his friends. You know, and the fear had been that their cancers would come back, you know, with a vengeance. And so far, we just haven't seen that.
Oh, that's wonderful. And I have never seen men as miserable as those men who have had their testosterone completely removed. It's really terrifying to think that any man would have to face that. And so, Dr. Morgentaler, you're really a god and an example to men. No, it's much more than that. But listen, how would you, you know, who would you consider putting on testosterone therapy? I mean, what are some of the symptoms that men present with?
Right. So, you know, listen, testosterone is a critical hormone for men and for women, as you know. And most of us walk around, and in some ways it's the most natural treatment that exists, because all we're giving to people is a chemical inside their body that they've always had. They've always had it. If somebody takes an antibiotic or an antihypertensive, the body's never seen those molecules before. I'm not saying that it's wrong to take them. I'm just saying that if you want to take something or be natural, testosterone is natural. You couldn't find anything more natural. And the goal of treatment is to get them back to where they were when they were, I don't know, 15, 20 years younger. And so we know what it does. We know what it does in animals, and we know what it does in humans at this point too. Now, but that doesn't mean that everybody needs to be on extra testosterone. But the numbers of men who are, so men need to have some kind of symptom or some sign of deficiency, and they need to have low levels. Now, the trick is, what's a low level? And
Right.
so people argue back and forth with this. And, we have two main blood tests that we look at in men. One is called total testosterone, or shorthand is just testosterone. And that's what all of us trained on. But much of the testosterone that's circulating in our system is attached to sex hormone binding globulin, this big protein that holds onto it, and holds onto it so tightly that as it goes past the cell that might need testosterone, the testosterone can't release to go into that cell. So the form of testosterone that does get through that lipid bilayer into the cell is the free testosterone. It's called free because it's unbound. It's not attached to anything. And so free testosterone can be measured. And it turns out that large numbers of men may have variations and generous amounts of SHBG, that carrier molecule, sex hormone binding globulin, which, if you have a lot of that carrier molecule, will also make it look like you've got a lot of total testosterone. But the part that's available to actually work is unrelated to it. So in my practice, we use both total and free testosterone. But really, most of the decisions are based on having a low level of free testosterone. It gets even a little bit more complicated, though, because there are about 3 or 4 different assays, different blood tests for free testosterone. And several of them have different reference ranges. Right. So if I gave, people, I say, what's the number? It depends on what the test is that's being used. But I can tell you that for most, the most common test now being used for free testosterone is called calculated free testosterone. And the units are usually picograms per mil. And if a man has symptoms and he has a level less than 100, I think he's a candidate for treatment.
Okay. That's good. I have a lot of men who come in and say, well, his testosterone level might be 250, 300. He's, let's say, 50 years old. And he said, well, I went to the urologist. Urologist said I have, my level is normal. And yet I'm exhausted and I have foggy brains and I'm no longer interested. The symptoms that you mentioned, which are really pretty, I can't get erections. I'm not thinking about sex. I like to work out. I can't lift my arms. I'm not building muscle. So what would you do with that man what would you say to those urologists or to men who have been told that? Because it's so common that I hear all the time.
Yeah, it's awful. We hear that story about 2 or 3 times a week, where somebody has absolutely low testosterone, like it's no question. And they've been told by their doctor, well, maybe it's a little low or it's borderline, but you don't need it. Let's do something else. And there is nothing else, so Viagra, Cialis, thank goodness we have those medicines, but all they help with is blood flow to the penis. They don't help with sex drive. They don't help with achieving an orgasm. They don't help with sense of well-being. They don't help with mood. They don't help with muscle versus fat. Like, it's not the same. But there is one of the biggest issues in our culture is that testosterone has a bad rap.
Yeah, well, it used to. I think you've changed that.
I think still for the medical community, for whatever reason, they've decided that it's associated with abuse, with improper prescriptions, with people cheat with it and body build and all this stuff.
Yeah.
And so there's a real reluctance, especially on the medical side, to treat. So I had a guy who saw the chief of endocrinology at one of our Harvard teaching hospitals, and he was early 40s and married, and his wife was upset with him because he just didn't have any sexual desire anymore. And she's going, listen, honey, we're young. Like what's happening? Do you not love me? You don't care for me? You got to get this checked out. He saw the chief of endocrinology, and he had low levels of testosterone, unequivocally low. Almost everybody would agree if your total is less than 300, you're low. And he was like 220 or so. And he tells me that the doctor confirmed that he had low testosterone, but he didn't need treatment because in the olden days, the queens used to have eunuchs, men who had their testicles removed, who would take care of the harem and often were considered wise advisors to the queens. He says, those eunuchs had it pretty good and your testosterone is better than theirs, so you're fine, goodbye. And what this guy says to me, he says,
that's ridiculous.
he says, I don't care about any queens from olden days. I care about the princess that sleeps next to me at night.
Yeah.
Yeah.
You know, men want, really, it's new for me taking care of men, maybe the last 10 years or 12, 14 years. You know, men want harder, longer, stronger, faster. And, you know, we need to support that because really that strength of their, of their physicality and their soul and their vision, you know, men are consciousness. And so I think testosterone is actually a consciousness hormone. Maybe good for the soul. I mean, is it a soul hormone?
You know, Prince, I think that what you just said is actually really important and very profound. So we're in a very tough time for men in this country in our current moment. It's not true in other like Europe, for example, but men are having a hard time figuring out what it is to be manly. Yeah. You know, and if we can set aside, you know, sexual violence and sexual abuse and just call it criminal, and we just talk about healthy, normal male sexuality, our fathers, our brothers, our husbands, our sons, it's a part of who we are. And we can make fun, you know, what you said, harder, faster, whatever. We can either ridicule men for that being some of their priorities and their focus, or we can recognize it and to some extent, great extent, honor it as something that is important for them. Yes. And if we do that and we let the men be big, manly in the grandest sense of the word, they're better partners. When a man feels good about himself as a man, just watch what he's able to give to his partner and to everybody around him. It's when men feel small, beaten, that they're fighting about every last little crumb. When they feel good about themselves and whole, then they've got the freedom to be everything that they've always wanted to be.
Yeah. You know, I mean, that is so beautiful the way you put that. And you're a leader of men and your words are important. And, you know, Dr. Morgentaler, I remember I was going up to Suzanne Summers' house once for an event. It was a beautiful dinner. And she has this little tram going up to her house. And I was in this tram with 3 male doctors. One was a plastic surgeon, very well known. Then there was a great internist. And I don't know, there was another man. And they started saying, well, I've been married 46 years. And I said, oh, that's amazing. You know, here's to love. And I said, how'd you do it? I had 27 years, which was very good. And they said, well, we've learned, I've learned never to say anything. And it's like, what do you mean? Well, if my wife says something, I say yes. And it's like, I said, no, come on. We have another, 30 seconds up here in the tram, right? That's not right. That's not manly. Please don't do that. You know, if we do that to you and silence your voice, we have silenced the lion's roar. And then we don't like you guys. You know, then that's the dirty secret is that, we control you with our power and then we end up sort of not liking you. So it's so important for men to be their true self, to be the vision of who they have for life and to help lead us. You know, women get really tired of, of always being the leader. I mean, we need our men. So you're bringing that back, Dr. Morgentaler. And, really, I'm really so much a part of your fan club as a woman, seeing what you're doing for men.
Well,
so
that's marvelous. I love that story because I agree with you 100%. Is that, but it's complicated, right? And a lot of what you and I are saying right now may not be politically correct. but men need their strength.
Yes.
And strength doesn't mean violence or aggression. Strength is contained within ourselves. And when we have true strength, then we earn respect. We feel like we merit respect, and we get it. Yeah. And, in terms of male-female relationships, I think a lot of the women want their men actually to be strong. They may not want it. It's not better than me or whatever. Is that we actually are, I started off talking at the beginning of this with the lizards, right? We are human. We are animals. We're a type of animal. We share 98% of our DNA with the great apes. And throughout the animal kingdom, there is male and female differences that are biological and that play out in different roles. And it's just so. Our brains are flooded with hormones early during a period of imprinting, before we're born as male and female. And it has an impact on who we are. And again, it's not one better the other. And, at work and community, there's no reason why everybody isn't equal. But we're different. And men need things, and they need to behave in ways that are different than the things that make men feel good about themselves are different than it is for women.
Yeah, thank goodness. Thank goodness. You've spoken about aging is one of the main reasons why testosterone is low, certainly as we age. What about stress? I remember one study that the Army did with young men in combat and what happened to their testosterone levels. I mean, what are some other causes of low testosterone?
Yeah, so stress can certainly do it. One of the common things is impaired sleep. So if you look at people who have impaired sleep for any reason, night shift workers, people with sleep apnea, anybody who goes in the hospital, testosterone, which is probably a combination with stress too, but testosterone levels drop. So one of the rules is you never bother getting a testosterone level in the hospital because it's always going to be low. We know that obesity lowers testosterone. It's associated with diabetes. We talk about general health issues with testosterone. There's amazing data coming out of Germany from this group that's had a registry now for about 8-9 years. And a lot of their patients are obese and had diabetes. Mm-hmm. When they looked at that group, at the end of, I think it was 6 or 7 years, around 30% of them had stopped taking any diabetic medication at all. They basically had cured their diabetes. That paper just came out. That's an amazing thing. How else do you cure diabetes? Now, the mechanism isn't voodoo. The mechanism is they lost weight, right? But losing weight is a hard thing to do on your own. You can do a diet, it all comes back. Every one of these diets, the end of 12 months, average weight is back to baseline. It's one of the hardest things humans do, other than with bariatric surgery. These guys had progressive decreases in their fat mass and their waist circumference and their weight. And so I'm certain that's the mechanism. But how amazing to actually be able to have a remission, if you will, of diabetes, type 2 diabetes.
That's amazing. That's amazing. Yeah, so testosterone, some men come to me and they say, well, I don't have any problems sexually, although a lot of men do. They start to lose their erections and the trigger of their erections and their, but they say, no, I'm great in that area. But my cardiologist says I have high LDL and small dense particles, of the LDL are also high. And, he's basically putting me on Lipitor. What is the story with testosterone and cholesterol and cardiac disease and cardiologists don't really like testosterone for men? It's really interesting.
Yeah. So the effect of testosterone on lipids looks like it's neutral. Cholesterol goes down, but HDL goes down too. That part I think sort of balances out. The heart stuff it's an interesting story. And again, like how society or medical communities work. In the 60s and 70s, there was a general belief, never tested, that testosterone must be bad for heart disease because men have much more testosterone than women. Then in the 80s, they started looking at it in these population-based studies, and they found out, no, that the men who get heart disease are the guys who have low levels of testosterone. And so the data are now quite clear from observational trials that having low levels of testosterone, just relative to the rest of your community, like if you're in the lowest 20 or 25%, puts you at higher risk of having atherosclerosis, angina, and mortality. Cardiovascular mortality is increased in the men with the lowest testosterone levels. Mm-hmm. By the way, COVID now,
yes,
Italian study, it happens if you have a low testosterone, you are at greater risk if you get infected of going to the ICU and dying, if you have a low testosterone. And some of that may have to do with the immune properties of testosterone, which are actually beneficial. So the heart stuff is now, I think, there have been a fair number of papers that have looked at it, none of them prospectively, all of them just observational. But I think most of that is showing that, if anything, testosterone seems beneficial for the heart, not worrisome.
Oh, that's wonderful. And over the years, I've followed, lipids very closely in men. And I always see, usually I see their hemoglobin A1C, their chronic sugar response goes down,
right,
and their friggin' cholesterol goes down. So I'm kind of surprised that you're saying that about lipids being neutral. I think we should do a study because, every man gets lipids every time. So that would be interesting to look at. So let's say we have the man, he has low testosterone, he has the symptoms. How do you choose to treat him? There's lots of different options.
Yeah. So, my favorite, I think the concept is if you can get testosterone up well enough, it doesn't matter how you give it to him, like he'll have a response. And so, we have a couple of different choices. We have pellets, we have injections, we have creams, we have a nasal gel. There's now a pill that's available. We don't have too much experience with that yet, mainly because of insurance is just learning how to deal with it. The old pills caused liver trouble, and so we never used them. The new pills don't seem to be a problem with that. My favorites these days tend to be the pellets because it lasts for 3 months, sometimes longer. So it's, it looks like a grain of rice. We numb up the skin and the buttock, make a tiny little nick, put these things in, and they sit in the subcutaneous tissue, in the fatty tissue, and they just dissolve over the course of 3 to 4 months. It's great. Levels go up, they stay up, they decline slowly. Injections been around forever. They work, but the levels go up, the levels go down. So it tends to be a lot of injections, usually weekly for the guys. The gels, when they came out first, it was like great. It freed people up from getting injections, but we find that a lot of people, maybe as many as 20%, don't absorb the gels that much. So there's a lot of getting blood tests, adjusting it, and then sometimes giving up. But for some people, that's the only way they want to do it, and it's okay.
Right. I think that being able to individualize treatment is absolutely critical. And I like the pellets too. Unfortunately, the pellets I get are too big. I like this little tiny grain of rice. I have to talk to you later about where you're getting them or if you're making them. So listen, I have young men who come in, and I remember specifically a patient who was 32 who traveled the globe really once a month. And he said, Prudence, I have not thought about sex in a year. Nothing, not a glimmer. I never get an erection at night. I never wake up with an erection. And he had all the classic symptoms and extremely low testosterone. It was 130 and 136, something very, very low. So is it appropriate to put a young man like that who temporarily on testosterone? And what about testosterone in sperm counts, for men who want to get pregnant?
Yeah, so that's an important consideration. So when we give exogenous testosterone, an outside source, it fools the pituitary and the hypothalamus into thinking there's enough of this around. And the hormones that then go down to the testicle, luteinizing hormone, LH, and FSH, follicle stimulating hormone, basically get suppressed. And the end result is the testicles go to sleep. So they stop making testosterone, they stop making sperm. So anybody that goes on normal forms of testosterone needs to be asked, are you planning to have kids anytime soon? Would you like to? And if they do, then we have a couple of choices. One is they can bank some sperm. Mm-hmm. And in other words, we can use other agents that will tell their body to make more testosterone on its own and which are okay for sperm. There are two main ones. One is called Clomid or clomiphene citrate. It's a pill. It's been around forever. It's used in women mainly, but it's been around for men. And the problem is that even though it reliably raises testosterone, a lot of the guys don't actually feel much. And that's because Clomid works by blocking estrogen. And amazingly, most people aren't aware of this. A lot of the beneficial effects of testosterone, especially in the brain, are by its conversion to estrogen. So we actually need estrogen. So we give Clomid often to young guys interested in fertility. It can help with sperm numbers sometimes, but we rarely see a robust response to it. The other one that works very well, though, is HCG, human chorionic gonadotropin. The problem is it's an injection that has to be given 3 times a week. So the guys have to learn how to do it. Sometimes it's pricey, but that will raise testosterone and it's fine for sperm. And sometimes we use it in combination with testosterone just to preserve. The testosterone is doing most of the work and HCG is just preserving some of the fertility.
Right. And, my experience is that when men say they don't want a child and they're done with their children, then change their mind and they've been on testosterone, when I take them off of testosterone, their sperm count comes back. I've never actually had a man. It's happened a few times over the years, a number of times, and they've all had their children. So that was very encouraging to me. It's not something, and I do talk about banking sperm for men too. Yeah. So Abe, we're coming to the end of our conversation, but I really would like to know, what makes you happy? What brings you joy in life? Because men are listening, you're a role model and I want them to be happy. I want them to be great and powerful. And so what makes you happy?
Oh, you're a sweetheart. And it's actually great that you ask these types of questions too. So listen, I've been very fortunate in my life, which is that I've had something that has engaged me intellectually for the last 40 years. On the through line is around testosterone and, is it really bad? Is it really good? How do we do it? And, at this point in my career, having done what I've done, I'm most proud really of the last few years. We started the first international testosterone society. It's called the Androgen Society. And if any of your viewers are interested, the website's androgensociety.org. And then as an offshoot of that, we just started a new journal, medical journal, which is called Androgens. And we're trying to bring together the medical community from all over, not just urologists or integrative medicine, but also endocrinologists, public health, basic science researchers. So we've got that. And, at the end of the day, for me, it's like if I feel like I'm engaged in my own mind, that makes me happy. And if it's doing something that creates a platform for others to also learn and help others with the knowledge that they get, that's a great day.
It's a great day. And you are I think when I see someone who's great that I want to emulate, that I want their qualities, I kind of come up next to them and they teach me how to do that. So you're a teacher of men. And I really think that every man deserves your books. They deserve your books. We're going to put up their website so they'll go see you. I just want to tell listeners that, Dr. Morgentaler is my go-to man. When someone has prostate cancer and they really want, testosterone, it's like, I can't give it to you. I'm not a urologist, so over the years, you have been absolutely an angel to my patients and to men. And thank you. I thank you so much, Dr. Morgentaler.
Oh, thank you, Prudence. It's marvelous. The thing we're working on now that really has me excited is the men who have advanced prostate cancer and are looking to have a better life and are willing to take a certain amount of risk, which I think is theoretical in order to have better quality of life. And so that part's been a lot of fun for me too and still keeps me going. Thank you so much for doing this. And it's been a pleasure to be with you.
Thank you so much.
All right.
Have a wonderful Boston day.
Thank you, Prudence.
Thank you for your generosity. Bye-bye, Dr. Morgentaler.
Bye.